Hello, everyone, and welcome to our July PQA Quality Forum webinar. I'm pleased to see everybody today. I welcome you as you join the webinar. My name is Amanda Ryan. I'm Director of Education here at the Pharmacy Quality Alliance, and today's topic is impacting patient outcomes through pharmacist-led virtual care model. As we do with every Quality Forum webinar, I would like to review a few quick housekeeping items. First, please do submit your questions during the presentation. You can use the Q&A feature that you will find at the bottom of your Zoom screen. We will have a panel discussion at the latter part of the webinar today, and I will include your questions in that discussion. Also, the webinar recording and the slide deck will be available to PQA members, and that will be within a week from today. And that will be available to you on the Member Resources Library section of the PQA website. Additionally, the webinar recording will be available on PQA's YouTube channel. And then lastly, I would like to encourage everyone to please take the quick 1-minute survey that will launch at the conclusion of today's webinar. Your feedback is very important to us, and we do appreciate your participation in that survey. Blueprint PQA 2025 is PQA's vision for excellence. It details our goals for advancing medication use quality, and it is responsive to the current needs of our members, the healthcare system, and the patients that we serve. I'd like to draw your attention briefly to Goal 2 in the blueprint, which focuses on pharmacist-provided care. Specifically, PQA seeks to advance the quality of pharmacist-provided care and also services that optimize medication use, adherence, and safety. As PQA pursues this goal, we seek to educate the broader healthcare community regarding opportunities to close gaps of care and improve medication use quality through the integration of pharmacists. One way that we accomplish this is through the PQA Quality Forum webinar series that you're attending today. And today specifically, you will hear from 3 pharmacists at Curator, who is a PQA member organization, and you will hear how they are impacting patient outcomes through their virtual care model that centers on pharmacist-provided care. Joining us from Curator is Zarah Mayewski, who is Vice President of Clinical Services. Also with us today is Tram, who is Curator's Director of Clinical Services. And finally, we have Priyasha Sarna, who is the Clinical Pharmacist Program Leader at Curator. You can read full bios of all 3 of our speakers in the email announcements and on the registration page for this webinar. I would like to thank all 3 of our speakers for joining us today. And with that, I will turn the floor over to Priyasha.
Thank you very much, Amanda, for that introduction. And thank you for giving us this opportunity to be here today and talk about this very important and relevant topic of pharmacist-provided care. When I think about pharmacy as a profession and how far we've come in regards to going beyond just a traditional dispensing role, the area that gets me the most excited is how pharmacists are getting involved in direct patient care. And they're providing services and caring directly for patients to ultimately help them live a longer and healthier life. And as a company, our mission is to make clinical pharmacists a staple for patients across the country. And so we've taken pharmacist-provided care to the next level by creating this scalable population-level virtual pharmacist-led clinic model, where clinical pharmacists coming in as a third-party member of the patient's care team incorporates themselves and collaborates with the patients and providers to generate this positive impact on outcomes, such as readmission rates. And that's something I'm happy to report that we have been able to show. So these next few slides will walk you through what this model looks like and what it entails, some of the outcomes and learnings we've had so far. So before I get into that, I will start with a poll question to have a better understanding of our audience here today. And our first question is, in what capacity is your organization using pharmacists? So you can go ahead and take a few seconds to read the different options there and select one that fits you best. Okay.
All right, Priyasha, I'm gonna
Yeah.
go ahead and end the poll. It looks like most people have had a chance to answer.
Okay, perfect. Okay, thank you for that. So it looks like we have a couple different responses here. Majority of the audience member is in the has other categories. We have a couple audience members that are in the community setting, in the patient care role in non-clinic settings. So that's great. Thank you so much. So our agenda for today is as follows. We'll go over some background information regarding Curator and what we do and the patients that we see. We'll go over details regarding the virtual pharmacist-led care model and what that looks like. And then we'll go on to discuss some of the outcomes we've seen so far. And we'll end this with a discussion regarding some barriers and solutions. So we hope to, by the end of this presentation, discuss the importance of real-time comprehensive data in the delivery of medication management services, demonstrate the importance of pharmacists as part of the interprofessional care team in optimizing medication use quality through high-impact clinical services, understand the opportunities to close gaps of care and improve medication use quality through this integration of pharmacists in a virtual setting. And lastly, reviewing best practices and experiences that have led to improved patient and provider satisfaction and implementation of pharmacist recommendations. Now, I'd like to go ahead and turn your attention to our second poll question here today. In your experience, can a pharmacist make an impact on outcomes related to value-based care? And we'll give a minute for that.
All right, Priyasha, looks like most people had a chance, so we'll end the poll and show the results.
Okay, great. So looks like a majority, 97% have said yes. So that's excellent. Thank you so much for answering that. Okay. So to give you some background on Curator, Curator is a national tech-enabled pharmacist-led medication management clinic that delivers medication optimization services to patients that are triggered by real-time events. So the patients that our clinical pharmacists are seeing are patients with uncontrolled disease states that are medication managed, such as heart failure, hypertension, diabetes, and others. Patients with polypharmacy that are on multiple medications that have regimens that are complicated, suboptimal, and recently altered, which make them a high risk for medication-related issue. And patients that are recently discharged and are at high risk for readmission. So our services are tech-enabled, which I'll get into in the next few slides, and are pharmacist-led, as I mentioned. Our strategy has been to embed these services to impact the medication reconciliation post-discharge measure and reduce readmissions. However, through that, we know that our team makes an impact on other HEDIS and STARS measures as well that involve medication optimization, such as statin therapy for patients for cardiovascular disease and diabetes, and medication adherence for diabetes, hypertension, and cholesterol. And we are now just being able to collect and analyze that data to show that value as well. But ultimately, with our services, our goal is to really keep patients safe, healthy, engaged, and empowered in their own care. So now I'm going to walk you through the virtual care model and the different steps that are involved in this process. The National TRC, or Transitions of Care Data and Alerting, notify us when one of our patients has been discharged or transferred from a care setting. Additionally, a patient can also be identified as a high pharmacist impact patient for population health and chronic disease optimization reasons. Once this patient is enrolled, the patient is initially contacted by Curator's clinical support staff which includes a team of pharmacy technicians, medical assistants, and pharmacy interns who engage this patient in the service and gather the initial medication information and ultimately schedule an appointment with the clinical pharmacist. The clinical support staff are highly trained to effectively engage patients upfront, which has been critical in patients accepting the service. And the pre-visit that's done by the clinical support staff also allows the pharmacist to really maximize their time with the patient during their appointment and conduct a visit that's high impact. Alternatively, the patient's care team may also schedule an appointment for the patient with one of our clinical pharmacists using a link if that method is preferred. The clinical pharmacist then conducts a virtual visit with the patient using Curator's medication management and optimization technology called Meds360, which I'll discuss in more detail in the next slide. And the clinical pharmacist will go on to engage the patient's provider as needed to optimize the medication regimens and ensure that the recommendations are being implemented. And finally, the clinical pharmacist will create a medication action plan, which includes the patient's current medication list, highlights key counseling points and recommendations, and sends this documentation to the patient and the provider. So this slide here gives you a little insight into some of the tech-enabled features that the clinical pharmacist has access to while conducting the patient visit. The medication profiles includes real-time medication behavior and usage for patients, and it's designed so that it's easy to identify critical drug interactions, therapeutic duplications. For example, if a patient picked up like lisinopril, losartan within the same time frame, or any dose changes that happened within the last year, as well as gaps in fill history that can point to issues with non-adherence or potential abuse as well. And alongside that, the clinical pharmacist has access to the patient's clinical profile, which includes real-time clinical data for patient encounters across care settings, which includes things like discharge summaries with the discharge plan, provider notes, problem lists, past medical history, vitals, labs, and others. We also automatically give back into the health exchange information exchange our own chart notes so that they're accessible for other healthcare providers. And I'm sure many of you have gotten the question of what a clinical pharmacist does that's different than any other healthcare provider during a visit. And to put it simply, the clinical pharmacist is providing a holistic approach to the patient's entire medication regimen. So they're discussing with the patient their disease states and health goals in context of their medication regimen, not only ensuring that the medication list is accurate, but also determining the return on positive health impact for each medication that the patient's taking. And this is really to ensure that their regimen is appropriate in regards to efficacy and safety. Some other key areas where clinical pharmacists focus on include drug and drug disease interactions, optimizing dosing for efficacy and safety of medications, identifying medications that are suboptimal or inappropriate or unnecessary, as well as identifying gaps in therapy where a patient is not on a medication that they actually would benefit from, and helping patients with medication adherence in many different ways, suggesting a simpler dosing schedule, resolving medication access issues, and making recommendations on alternatives for medications that may be cost prohibitive. Clinical pharmacists are also trained in motivational interviewing, which is patient-centered and collaborative. And this really helps to strengthen patients' own personal motivation, which ultimately then allows them to reach their disease state goals. So now I'm going to turn this over to Dr. Tram, our Director of Clinical Services, who has devoted her career towards advancing innovative techniques in order to improve health equity. And she'll be discussing some of the outcomes that we've seen with this model.
Thank you so much for that introduction, Priyasha. So now that you've learned about our virtual care model, you're probably wondering how well is this model working And in an internal review of our data, we found that in 2 independent settings, one of a health system and another with a health plan, our virtual care model showed a reduction in 30-day hospital readmissions and ED visits, and impactful provider engagement and increased patient satisfaction, which we'll review in more detail in the next few slides. But before going into the data, I do want to note that, we're able to schedule and see about 50 to 70% of patients referred through our strong omni-channel work. Then all of those, we go on to close MRP gaps, like Priyasha mentioned before, and then we realize reductions in readmissions, ED visits. So the next few slides I'll share will be the product of those visits. Okay, so when we review more closely at the health plan, the patient population was Medicare Advantage patients who were discharged from an acute care facility and had a comprehensive med review within 30 days of discharge. So in this group, there was a 63% statistically significant relative risk reduction on 30-day readmissions and a 3% in 30-day ED visits, which to me, that's really impressive to make that sort of impact on these types of outcomes, which I could be a little biased. And on the next few slides, I'm going to share examples of the patient visits and the kind of impact we're seeing on a daily basis to give you all a flavor for how the pharmacists integrate and make a difference in care and how we're able to move the needle. So the first patient is a 76-year-old female discharged after scheduled thyroid removal surgery. She has a past medical history of high cholesterol and heart attacks requiring multiple stents and long-term treatment with dual antiplatelet therapy, so aspirin and Plavix. Our pharmacist followed up with the patient about 2 weeks post-discharge and discovered the patient was instructed to stop the DAPT prior to surgery, which makes sense to decrease the risk of bleeding. However, the patient was not instructed to restart the DAPT post-surgery. So the pharmacist contacted the cardiologist, and the cardiologist agreed that the patient should have been instructed and should start both aspirin and Plavix immediately. So the pharmacist contacted the patient and both meds were restarted, which this could have possibly have led to a readmission due to another heart attack if both medications were not restarted. Additionally, the pharmacist ensured adherence to their statin and access to all medications, and also ensure that the patient received 90-day supply for all of her medications. Okay, so this is another patient case showing how the pharmacist takes a holistic approach to make an impact on health outcomes, really implanting themselves as part of the care team and actively resolving problems and being that connective tissue for the patients on their TOC journey. So this is a 68-year-old male hospitalized for knee surgery, discharged on tramadol and only tramadol to manage his pain. The patient had already seen the surgeon post-discharge, and then 2 days later, after seeing the surgeon, had the initial visit with our pharmacist. So on this virtual visit with the pharmacist, the patient reported there were visible pus oozing from the incision site with really no instructions on how to change the dressing on his wound. So upon further inquiry from the pharmacist, it appeared the patient's symptoms were consistent with cellulitis. So it was red, it was swollen, warm and tender to the touch, and the patient stated that he was not given anything for it. So the pharmacist, who could see the patient's fill history on our internal platform, asked the patient, are you sure? Because I can see your fill history and it looks like the Bactrim was filled 2 days ago. Do you recall anything like that? When you were at the follow-up appointment? The patient stated, no, no one told me anything about it. So the concerned pharmacist called the surgeon's office immediately, spoke to the nurse to clarify, who the nurse informed the pharmacist, yes, actually, indeed, the Bactrim was ordered 2 days ago, but obviously the patient was not aware. So the nurse said she would call the patient and educate on how to care for his wound, inform of the Bactrim prescription waiting for him at the pharmacy, and plans for a scheduled in-office debridement, which the patient was also not aware. The pharmacist also did their due diligence to close the loop with the patient and provided education on the Bactrim and informed the nurse would be calling to provide additional details. So in this case and the one prior, you can see how there may be gaps in care during that transition period and even post follow-up visit with the providers, where really having the clinical expertise from a pharmacist is crucial to impact outcomes. Okay, the next slide. Yep. Okay, so this is a good segue to now share some of our provider engagement and acceptance results. So this is a subset of patients discharged from an acute care facility, referred from a health plan over the course of half a year or 6 months. And this is how many required provider intervention. And we define provider intervention as anything that warrants a prescriber change. And I know there's a lot of information on these slides, so I'm not going to go into too much detail, but just provide, a higher level overview. So there was a total of 611 med problems identified, of which 224 required provider interventions or prescriber change. The remaining medication problems that did not require provider engagement included adherent issues or knowledge gaps where the pharmacist counseled the patient. So 42% of these interventions that required a phone call to the provider had a 76% acceptance rate. And then 58% were included on the medication action plan and sent to the provider with a 55% acceptance rate, which is really impressive data considering we didn't have any sort of historical relationship with the provider. So the fact that we were able to engage with the provider in an indirect manner and have a 55% acceptance rate, I'll take that. Obviously room for improvement, but not bad, especially given the context of, like I said before, not having any sort of relationship with that provider. And then what's more powerful than that acceptance rate are the interventions the pharmacists are finding. So medications requiring dosing changes, therapies that are suboptimal or duplicate. So the pharmacists aren't saying, these meds aren't right and I'm moving on. They're actually saying, hey, something isn't right here and I'm recommending a change. And then when you look at the refills needed for 85%, these aren't patients that are saying, I'm out of this medication or I need that medication. These are pharmacists identifying a medication that should have a refill and don't. And these are vital medications like DOAX after a DVT or PE, or Brilinta after a heart attack and stent placement. Because oftentimes these post-discharge patients, they're only receiving 30-day fills with the expectation that the patient will follow up with their primary care provider or other specialists who will then provide additional refills if needed. And sometimes, the post-discharge appointments are scheduled greater than 1 month, or the patient canceled the appointment and rescheduled, the appointment past 30 days, or sometimes they think they only have to take it for 30 days because the instructions on the pill bottle say times 30 days. So it's these types of interventions our pharmacists are finding to have impactful provider engagements to improve outcomes. Okay, so we've shared what provider engagement looks like with our virtual care model and the impact we're having on optimizing medications and improving med safety. Now you're probably wondering, what are our patients saying? Do they like this virtual care? So typically after the virtual visit with the pharmacist, the patient is invited to stay on the line to answer a brief 3-question survey regarding their visit with the pharmacist. And for each question, it asks the patient to rate on a scale of 1 to 4, 1 for strongly agree and 4 strongly disagree with being satisfied with their care, satisfied with the care they receive, clearly understanding the purpose of their medications, and if they strongly agree or disagree, to be able to ask the pharmacist about their medications. And overall, you can see that the patients report high satisfaction with our pharmacists, ranking strongly agree to all 3 of those questions. We also have some patient testimonials sharing how the pharmacist helped ease their anxiety that they were feeling post-discharge, and how nice it was to have these visits in the comfort of their own home, and having the pharmacist review their medications in a more personalized detail, which was way better than having to try to understand all of the medical jargon typically given on the pre-printed med info sheets given on discharge. So that was really nice of them to share their experiences with us. Okay, so when it comes to patient care, hopefully I was able to give you all an idea based on our patient stories and testimonials you just heard that our virtual care model is a patient-centered approach. Being in this virtual setting allows us to connect with patients via telephone when and where it best suits them, whether that's at home or at their son or daughter's home. They don't have to worry about transportation to their appointment or any crazy technology to speak with us, which is typically a concern for many patients when they hear the word virtual. Oftentimes, our pharmacists will serve as the liaison between the patient and the entire care team by helping to coordinate post-discharge appointments that are often missed. And we communicate to the care team to resolve issues related to medication access. We also have pharmacists that are native speakers of different languages, or we can tap into our translation services if we don't have a pharmacist that does not speak the patient's language. We can also translate important health documents like the medication action plan in Spanish, with hopefully other languages in the pipelines for the future. Our pharmacists are also able to get to the root cause of issues to help improve med adherence. I'll give you one last example here. There was a heart failure patient who had a history of being in and out of the hospital for heart failure exacerbations due to non-adherence to his loop diuretic. This patient was at the point where most of his care team had given up on him because they figured he just didn't care about taking his diuretic, and there was nothing they could really do to convince him otherwise. So when I finally got the patient on the phone and started to ask about his life at work and his life at home, I discovered he worked third shift and slept during the day until about 4 or 5 in the evening. And the reason why he wasn't taking his water pill in the morning, as instructed by the doctor and what was listed on the pill bottle instructions, was because it was disruptive to his sleep. So I asked, is this the only reason why you don't take this water pill? And the patient is like, well, yeah, because, I didn't know that I could take it at night, and it works at night because it says to take it in the morning. And I think, I think you know how the rest of the story goes from that point. The patient was counseled he can take the water pill at night. So technically that was his morning, and he pretty much stayed out of the hospital. And I think oftentimes as healthcare professionals, and I know we're all guilty of it, make assumptions about patients and their lifestyles, and who knew that the word so simple as morning could have such a huge impact on readmissions. Our pharmacists are highly trained. We pause, we get to know the patient, we use motivational interviewing to connect with them and personalize their care to help them set and achieve their goals, to live healthier lives and keep them out of the hospital. And then there's one last thing I want to share is the Curator Cares program, which helps qualifying patients receive their necessary medications at no cost, while we help them find lower cost alternatives, or if the patient's waiting for assistance programs to kick in. In addition to that, we currently work on a process to have the capacity to help patients identified with any social issues, such as those needing food assistance, housing, wellness, transportation, connect with resources in the area in which they live. And when I say connect, that's not just passing along a number to the patient, hoping they call and able to get in touch with someone that can help them. This will actually be connecting to a community health worker on our team in real time, assessing their social needs. So that's something really exciting that is to be able to offer that soon to our patients. So next up, we have my favorite barrier blasting fearless leader, Zarah, who's the VP of our clinical services, to close us out and discuss some of the challenges we've encountered that have pushed and inspired us to be innovative in developing solutions for our patients.
Thanks, Tram. Good afternoon, everyone. Before we jump into the poll question, I just want to back up a little bit on this topic of barriers related to pharmacist provided services or clinical pharmacists, and tie together what Priyasha alluded to in the very beginning in this presentation, that My goal and dream, as well as everyone at Curators and many of you, is that clinical pharmacists become a mainstay in care teams for patients within the next 5 years. I think anyone you ask in the profession of pharmacy knows that where we were 5 years ago, where we are today, and where we want to be in 5 years are all very different. And we're in the center of this identity crisis where our patients and our mothers and fathers and uncles and aunts, when you describe what a clinical pharmacist is in under a minute, they might not totally understand yet. And even the profession of healthcare doesn't totally understand yet. And because of that, and in addition to an ever-changing healthcare sentiment in the United States, there are barriers that are going to come up in implementing clinical pharmacist practice. And we need to come together and share best practices and ideas for what to do when those barriers come up. I think the most important thing that we can do to obtain this goal in the next 5 years is to really grow our grit, and that being the delta between this is what I would love this clinical pharmacist service to look like and the patient population that I'd love to impact, and understanding that there's a version 1 and then there's a version 2 and then there's a version 3, 4, and 5. I think of this as if you could think back to being the little kid in the playroom and you're trying to build a tower of blocks, but there's another little kid that just keeps coming and crashing the blocks down. I have 2 toddlers at home, so this is like near and dear to my heart. We have to embody continuing to build that tower of blocks up during these next 5 years as we continue to change the profession. So I want to share with the group some of the best practices that we've learned, especially across common barriers that I think the entire industry is facing: patient engagement, provider engagement, those sorts of things. First, I want to start with a poll question because I'll tailor a little bit of our experience to potentially what you all are facing.
All right, looks like give everybody about 1 more second here. And we will end the poll and share the results.
Thank you, Amanda.
Sure.
Just kind of reading through this. Perfect. Okay, let's hop into some of the barriers that we've learned. If you don't mind changing to the next slide, that would be fantastic. Thank you. So I want to start from a top-down approach here. The first is you have either your health system, payer, physician group buy-in to launch a clinical pharmacist service. And you have your best intention set on inclusion, exclusion, where you're going to impact. And now you're having issues with getting referrals, or how do you get that patient population into the funnel? And this piece is really important to take a step back, and we're all addressing this place in healthcare where almost every single healthcare professional has a massive list of priorities that are all high. So it's important to remember that remember tos are remember nots. So starting a workflow that involves a constant referral from a provider or a care navigator is a great ideal place to start, but be willing to get scrappy and go find the patient yourself and ask for a referral yourself or engage them in the funnel if those referrals aren't coming through. The other piece here is definitely set criteria where you know you're going to make an impact. The patients that it's well studied, the pharmacists are able to help here because they have chronic disease states or are at high risk and require medication regimens that are optimized. The last piece I want to say about this part is goes back to that the healthcare industry doesn't yet know exactly what a clinical pharmacist can do. So the best approach I've seen in my career is asking the players at the table, what are the biggest pain points within your health system or your patient population? Is it diabetes? Is it transitions of care? And then from there, saying these are the ways that a pharmacist can impact those. And that's where this is how I can design my workflow to you. So I really recommend starting with those pain points, asking questions there, and then plugging into the CMO or the manager of the clinic and saying, let me try out this workflow because I think this is how you're going to get the best ROI of a clinical pharmacist, because this is where I'm going to really impact patient lives and outcomes. The next challenge is you get the referral, you have 500 patients knocking at your door that are potential opportunities, but the patients don't want to be seen or they don't see the value in the pharmacist visit. Some things we've learned here along the way are, and I think a question already came in the chat about this, is you could take two approaches here. You can try to sell the value of a clinical pharmacist service, or you could just start caring for the patient like any other provider would. I'm a clinical pharmacist. How are you doing after discharge? I want to learn more about, are you having any side effects? And just hopping right into it. We've actually found more success that way than having to sell yourselves up front. The other piece here too is the patient says, I already have a pharmacist. And we've found lots of success in talking about how the clinical pharmacist partners with the entire care team, including their community pharmacist, who they can call and gather more information and get recommendations there as well. And the biggest piece about the patient aspect is we have found leveraging technology and multiple omni-channel outreach is important. So our patients are sent text messages once they're referred to our service that gives them time to actually open up a website that says who our clinic is and what we do. So it's not a cold call. And we have also leveraged clinical support staff who are medical assistants or pharmacy techs to be the initial outreach to the patient. I've worked in other practices where the initial outreach after referral to the patient can be front office staff or a non-clinical person. We found a lot of success in adding a clinical person up front to leverage, connect with the patient quicker, really understand the pharmacist's value in the service. The last piece here is provider engagement. And this is probably one of my most proud accomplishments within Curator Clinic and our team is coming into an open system where we're dealing with hundreds of different primary care doctors as well as specialists who do not know us. There are certainly specific contracts where we are partnered with the doctors and they're aware of who Curator Clinic is, but that's not all and not even most. And some of the lessons we've learned along the way is when you call the provider office, starting with, I'm calling from Curator Clinic. So the word clinic means something different to a provider office than saying that you're a pharmacy. And also this aspect of saying that you spent X amount of time having a visit with the patient. So it really frames to the provider, you're another provider of care, and you spent 30 minutes talking one-on-one, understanding deeply this patient, building buy-in on the recommendations, and not just understanding the medical literature, but understanding the holistic approach to the patient and specific facets of their lives. Like Tram had mentioned, the Lasix dose, and she totally understood what was going on in that patient's lives because she spent the time, the 20, 30 minutes in that visit to get to know them deeply. The other piece here too that we found success in is try to mirror and match with provider groups a workflow that's similar. So if you call a primary care provider's office, you're going to reach a medical assistant or a nurse. So we've also leveraged some of our clinical support staff, because that's typical flow at a clinic, to be the person calling the doctor's office and saying, hey, my provider in my clinic, Zarah Mayewski, just had a 30-minute visit with your patient and has the following recommendations. So we've leveraged some of that as well. Those are some of the highlights that I'd love to hit on of barriers. I want to open the floor to questions here, and also love to hear other people's best practice throughout their experience, because I do think that this is a journey that I hope will be in 5 years, but this journey to make clinical pharmacists a mainstay in patient care and household name and understanding, it's going to take all of us, and it's the right thing, as you saw in what Tram was showing with impact and outcomes, and also really high trust that patients have in pharmacist care. So there's a lot of opportunity here, and this is just a really small sliver of a best practice. I know there's lots more out there. So Amanda, I'm going to hand it over to you to lead the Q&A.
All right, perfect. Thank you, Zarah. Thanks all three of you for sharing your experience with us today. We've actually had quite a few questions coming in while you were speaking, and we will try to get to as many of those as we can during our Q&A session here. To the attendees, if you've got more questions, please add them to the Q&A. We will keep monitoring that throughout our session, and we look forward to answering your questions for you. So I'm going to start here with a question that was related to encounter notes. So earlier in the presentation, you talked about encounter notes and being able to share those with other providers. Can you give a little bit more information about how that process works?
Yeah, I could take this one. So this one is about health information exchange databases, and we gather information from health information exchanges. We also feed information back. So think about this as your Epic Care Everywhere's, that sort of lane. I hope that helps.
All right, yes, very good, thank you. The second question is comparing the services that your clinical pharmacists provide to medication therapy management and a comprehensive medication review. So is this the same? Is it different? Can you kind of compare and contrast those for us a little bit?
Sure, I could take this one too really quick. The best way I would describe the differences here, we've really tried to swim primarily in a CMM lane, and the differences there being embedding ourselves as much as possible within the care team. We do have some patients where it's a one-time touch point, but in general, we try to do a multiple touch point, and we're really working on health outcomes as the goal, not just a medication review, but also reducing your rate of readmission, improving your diabetes, hypertension, a very holistic, embedded within the care team approach. And
Okay.
some of that, just to add a little bit of flavor here, we have baked in time in our model for the pharmacists to really dedicate to creating those pathways with other providers to move the needle on recommendations and outcomes. I think that's where you find success there.
Okay, very good. Thank you, Zarah. I think Tram addressed this in her comments, but we did have a question specifically about languages and the number of languages that you all speak on your team. And then could you talk a little bit more about the process that you follow if you don't have someone that speaks that patient's language?
So we do currently have Spanish as a translator language that we can, if we don't speak Spanish, we can use a Spanish translator. We do hope to expand to more languages though in the coming future to continue to expand our reach to patients. And Zarah, do you have anything, sorry, to add to that?
Oh, no, that's good. I think our patient population right now, Tram, correct me on this, is 5% Spanish speaking is the largest population, and we have multiple pharmacists and clinical support staff on the team that speak Spanish. And then
Yes, that's correct.
and then beyond that, we do use a translator service that you can call in with the phone and we get the primary language when we get the patient referrals. So we can use that translator service on first attempt and also text message, those sorts of things.
Yeah, and I think, Priyasha, you may be being modest, but you also you speak a language too, which I don't think you're giving yourself credit for that. And then I also speak a language as well, so Vietnamese, and I forget the language you speak, Priyasha.
Hindi, yep.
Yeah.
Okay, very good. Thank you. We've actually had a couple of attendees that are interested in the reports that you shared around provider acceptance of your recommendations. So they're wondering just high level, kind of how you take that data, how are you able to condense it and really nicely display that data? And then how do you track those? Do you look at refills to see if a particular fill of a medication to see if it was accepted? Do you have communication from the providers on the team? Can you just share us a little bit more about that process?
I can take that question. So it's actually a combination of all of the above that you mentioned. So depending on how quickly we can resolve issues, and I think on one of the slides I share that some of the issues that we discover, warrant an actual provider intervention where we actually physically have to call the provider office and speak to a nurse or actually the physician. So if we're able to actually speak to the provider and resolve in real time, within our internal system, we're actually able to track the provider intervention. So we're actually able to tag per medication each issue and then tag each issue that we have, whether it's been resolved or unresolved or pending. And then we have a really great data team that's able to kind of analyze it all for us and box it up and display it in a nice, pretty format like what everybody saw here today. And also there is a little bit of that too, based off of fill history. Sometimes our clinical support staff will also follow up maybe a week or two later with the physician and close that loop as well. So it's definitely a team effort.
Yes, absolutely sounds like that. Thank you, Tram. This question is about reaching the patient and what happens when the call goes to voicemail. This attendee mentions that they tend to screen their calls. Do you have, challenges related to that, and how do you address those particular challenges?
I could take this one. This is one of the areas I feel really, of many, blessed to be a part of Curator. We have an amazing product team that gets really in the weeds with us about how to make patient engagement better, which for us, we define as getting a patient from referral to in the door at that first visit. And we dive into things like, what are the right phone numbers? What's the right caller ID? What's the right website? What do we send in the text? Gosh, there's so much more here. Tram, Priyasha, what am I missing? But this is certainly, it's a barrier. The first couple patient populations that were enrolled, we had a lot of legwork here, and there was a lot of time dedicated to making this more digestible and more likely for the patients to come into the funnel for service. And certainly in patient populations where we are embedded, for example, in health systems, we have a lot of the discharge team or the providers talk about our services so they know to be expecting the call.
Yeah, and to add on to that too, in the environment that we work in, I think sometimes we don't give enough credit to our friends in the background who are constantly reviewing the data when we close out visits as left voicemail, but they're constantly reviewing to see how many left voicemails we're leaving, how many patients are calling back. Is there anything specifically that we can change to improve on? So, as our pharmacists are seeing patients every day, we have a great team of people in the background who are constantly analyzing data to see how we can move the needle on, leaving voicemails. And if we're leaving a voicemail, what's the goal of like the number of patients that are calling us back? Is there something we can say differently? Priyasha, I don't know if you have anything to add, or Zarah.
The one thing I would add here is, in general, we see of the referrals and the patient population, we end up seeing anywhere between 50 and 80% of those patients, which is pretty great. Obviously, the ones where we have a layup and they know to expect the call, it can be a little bit higher, but we've actually found some of the best metrics for when we successfully reach patients are time of day that we call them and having a good working phone number, which I'm sure many of you can relate to. So it's sometimes the simple things.
Absolutely. And I love the data analysis, looking at what's working, quality improvement 101 at its finest, and how to continually make your services better. So thanks for sharing all that with us. I've actually seen, I think, 3 or 4 questions on this one. So wanting to know just a little bit more about the numbers. How many patients does a pharmacist typically interface in a day? How long are those encounters? Any information you can share around that?
I can take this question. So our pharmacists on average see anywhere between 10 to 12 patients per day, up to I've seen as much as 15 per day. The patient visits, we've really streamlined the process when the clinical support staff schedules the patient. Depending on the number of medications, the visits can be anywhere between 15 and 20 minutes or 30 to 45 minutes. And that way, that really gives the pharmacist an opportunity, like I mentioned before, to get to know the patient on a personal level so that we can really get to the bottom of if there's any issues and helping the patient set their goals. Hopefully that answered that question.
If it's okay, Amanda, I'd love to, I've seen a few questions in the chat about this reimbursement, ROI for services, value-based care. Can I tackle that one?
Absolutely, please do.
Okay. This one's a fun one. A lot to be said about this. What I will say is, it pains my heart that pharmacists cannot bill for services, because wow, how much easier would it be to show an ROI. And before Curator, I practiced in Washington State, where pharmacists could bill commercial insurances. In general, even that didn't get to a complete ROI. The silver lining on this is that clinical pharmacists, in order to show their value, have to show that by moving the needle in value-based care, which is where healthcare is going. So the silver lining in my mind is that we might be one of the best prepared professions when that needle switches all the way to value-based care. And the way to do that is by setting up your programs from day zero to collect data and compare that data to other populations, ideally running side by side real time with yours, of how you're moving the needle on readmissions, on diabetes care, hypertension. You pick it and then measure it. And that's the value. And that's really where healthcare is going. We've really leveraged ourselves off of that. And we have been of the philosophy that we give our amazing clinicians who are very experienced in direct patient ambulatory care the time to build deep relationships with patients and their care team. And we have an awesome data team in the background that's picking up all the pieces and collecting that value. On part of that data team, we also have a pharmacist who kind of helps drive where to look. But there's, in my humble opinion, it's hard to have a successful clinical pharmacist service in the ambulatory care realm without this ROI on value-based care in one way or another. You have to have that data. Anything else to add there, Tram, Priyasha?
I think you said it best.
I did want to close with one more question related to health equity. I'm curious if you've done any data analysis stratifying your patient populations and outcomes. If not, have you had any conversations related to equity? How does that kind of enter into all of the services that you provide?
I could start this one. I'm just going to be totally vulnerable in this, that this is a thread that I feel very incomplete on. Health equity is one of our company values, and we live and breathe that value. I was just in a meeting the other day with a group of pharmacist leaders where we were talking about what is the value in CMM related to health equity, and there was a lot of pause. The reason why is that there seems to be paucity in the literature here, and some of what I've explored in the past few weeks is the true North Star of how you look at health equity doesn't seem to be greatly defined yet. I would love to, in the next 6 months, be able to answer this question better. And I challenge all of us, both within PQA, Curator Clinic, all of healthcare, all of pharmacists, to spend more time on this so that we're not pausing so much when this question is answered. Tram, Priyasha, other things to add here?
The only other thing I would probably add is, there has been conversations internally about how to stratify different patient populations and demographics and how to tackle this. But I mean, you are right, there is a lot of pause because I feel like there's just not a lot of information out there. But to answer that question earlier, we are not experts at it. I love the fact that Zarah, became vulnerable with it. Love to hear anyone in the audience who, have learned anything with health equity. If you have tackled it, love to learn from you guys.
The one thing that you just sparked the firework in my brain, Tram, is some of the data from one of our patient populations where, because of the multiple languages that the team speaks, they were actually really surprised by the patient populations we were able to engage. I think that starts to get in that lane, but we haven't dug. We have a deeper place to dig here and homework.
I appreciate your candor on that question, and agree a lot more conversations to be had and homework to be done. I would like to thank the participants today. So many questions. I apologize we were not able to get to all of them, but a fantastic discussion. Thank you to the Curator team for joining us. I'm going to finish up here since we are out of time with a few announcements. I'm going to put some things in chat for you and then go through a couple of slides. So the PQA Social Determinants of Health Resource Guide is a resource that we put out to document real-world SDOH services that are promising for improving the quality and safety of medication use. So you can access that guide. I put the first link in the chat. If you have not seen it, please do take a look. PQA is currently developing a second edition of the guide. If your organization is offering pharmacist-centered services that address SDOH or health equity, we invite you to submit them to PQA for consideration for inclusion in the second edition. The deadline for that submission is Monday, August the 1st. You can use the second link in chat to submit your interventions. And then PQA invites members to attend the third quarter stakeholder advisory meeting, and that will take place on Wednesday, August the 10th from 1 to 2 p.m. Eastern time. This will be a members only staff hosted meeting to share measure development and maintenance updates, as well as engagement opportunities. The registration link is available in the member resources library on the PQA website. We will also send email announcements about that as well. And then finally, our next Quality Forum webinar will be on Thursday, August the 18th. Members from the National Transitions of Care Coalition will join us to talk more about pharmacist-led transitions of care. And then I put that registration link in the chat for you. So please sign up if you're able to come. And we look forward to seeing you there. Thank you so much for joining today. And I hope you all have a great day.